Okay, hopefully you can all see a lovely picture of pelvis and thigh, chapter 6 here. Let's talk about some of the muscles we talked about in the homework. Okay, super duper important. This is a side view looking at the lateral side of a thigh, right? There are actually two muscles that feed into the IT band. And what are those two muscles? Anybody? Yes, Ms. Mejia, please.
The gluteus maximus and the tensor fasciae lata.
Thank you. The gluteus maximus, tensor fasciae lata actually triangulate and then come down in this band. They actually triangulate and come down in this band. It's very clever because you got this tilty pelvis and you kind of triangulate it and bring it down into this IT band. Yes, Mr. Tate.
And sorry, I got a phone call just then. I just want to double check to make sure that you're recording this, please.
I am, sir. I'm recording it. Yes.
Okay.
Yep, and I will post it. Thank you for reminding me. Because you're right, if you tell me afterwards, it doesn't really matter. Okay. So the other thing I want you to think about is the gluteus maximus. Yes, it feeds into parts of the IT band, but it also extends to your femur. The tensor fasciae lata really is the muscle, or the IT band really is the tendon for the tensor fasciae lata in a way. You know, tendons attach muscle to bone, and what attaches the tensor fasciae lata all the way down to the tibia? The IT band. So that's another way of looking at this muscle. And this triangulation is very important too. We're going to see it in lots of places in the body here. Okay. And then because it comes down the lateral side, lots of people wrote in their homework like, hey, this provides stability of the knee by grabbing on all the fascia that wraps around the knee. It's like packaging up a box. That's all true. But very specifically, it protects the knee from blowing out, from bending out, from folding out, from pushing out laterally, right? Whereas the pes anserinus helps it medially. But it's true, it tightens up all the fascia around the knee too. It's all that's true. I just wanted to point out it's very specifically, it helps with lateral blowout. All right, let's see. And here's a lovely picture of the psoas major, which is part of the iliopsoas. It's still in front of your body, so it still helps with anterior tilts and flexions of the hip. And this is the one that was very deep inside your stomach, so it's very hard to reach. It can be done. You can go in through the stomach and reach it and pin and stretch it, but it's not my favorite way to work it at all. Yes, Ms. Trotter, please talk to me.
Is this the one with that one stretch you showed me? Is this the one that you were?
Yes. So because this muscle flexes the hip and it's hard to reach, and don't get me wrong, by the way, there are massage therapists that go in directly under the stomach, and they're much better at it than I am, but it's still always tricky. So I like to stretch it, and because it creates a flexion of the hip, if you create an extension of the hip, you can stretch it. And you're right, Ms. Trotter, what I showed you was essentially pulling the leg back. But since I couldn't pull the leg back as much as I wanted, I pushed the hips in. But pushing the hips in is the same thing as creating an extension of the leg. And so, yes, that's the one I do with them face down, and I push their hips down and keep their leg up because I want to stretch the psoas major, and it's not shown in this picture, but the iliacus, which, let's see if they have a picture. They should. No, they don't. Anyway, the iliacus is in front there too. And it goes to the same place that your psoas major does. And so you're stretching both those. You're stretching the iliacus and the psoas major, which we call the iliopsoas. That's two muscles. And you can stretch it by putting somebody into a lunge, basically. That's what a lunge is meant to stretch. And by the way, it hooks into the psoas major, hooks into your lower back on the inside. So people with back problems, it's not crazy to try to stretch it. Because when it's short, it'll actually pull on the inside of my low back and actually give me extra exaggerated curve in my low back. It'll actually give me lordosis. Yes, Miss Walker T.
Do those, the iliacus and the psoas major, do they always work together?
Yeah, we don't, I mean, Miss Walker, we don't really know, but yes, we have every reason to believe that they basically can't work independently. They seem to go to the same attachment site, and they seem to be set up to kind of help grab your pelvis and grab your low back and move them at the same time towards your leg, or lift your leg at the same time towards those two locations. So we have every reason to believe they always work together, and that's why they're referred to as the iliopsoas. Yes. Yeah. Yes, Miss Mejia, please.
So I have a question. It's probably super easy.
I hope so.
But if someone has, oh, I don't even know, like maybe shortened iliacus, because I mean it's literally in the iliac fossa. So
Yeah.
I don't understand if that can actually happen because it's there. I mean, does that make sense? Like, can it be a shortened muscle?
Yeah, it seems to be. So we notice it especially people that sit for long periods of time. Because when you sit, you're in a flexion, but you're not creating a flexion. You're just sitting there. And so the iliacus and the psoas major can shorten at that point.
Okay.
And then what happens is people don't sit up all the way. So what I mean is, I'm oversimplifying, but if I'm sitting down like this in a chair and this is my psoas major and stuff, and it doesn't lengthen all the way, then when I get up, I walk like this.
Okay.
And I'm exaggerating to try to make a point, and that causes problems with my neck because it's way out here, right? But it doesn't have to be much. Let's suppose I just couldn't straighten up quite all the way. Got my belly now here, my back's just a little bit back. This would be pretty uncomfortable after a while because I've got to go all the way to here to get straight up. So it wouldn't have to shorten that much to give you problems, and yes, we do think that totally happens, and we think it's probably both of them in that case. If you're going to ask me if I've ever seen a situation where just the iliacus was shortened and not the psoas major, I would tell you that I have no idea. Because I stretch them both. I don't look for one or the other. Does that make sense?
Yeah.
I just go, okay, it seems like that iliopsoas complex is tight. I'm going to stretch it. Yeah.
Okay.
And I'm actually, to be very honest with you, not even always looking at that. I'm just like, oh, there's an anterior tilt. I'm going to stretch all the hip flexors. And that's the iliacus, psoas major, tensor fascia lata, sartorius, rectus femoris, glute min, and sometimes glute medius, depending on how nitpicky you want to get. And I would probably hit all that stuff. And luckily, any stretch where you're putting them into a lunge will take care of all that stuff at once even. So that's some of the stuff I would do, yeah.
Okay, for some reason I couldn't think that a hip flexion would make it short, but thank you.
Well, I hope I answered your question properly.
No, you did.
Okay. I mean, normally, by the way, I mean, it does shorten and then it releases, right? So all muscles shorten. We want them to shorten. That's called contracting. But we're concerned about the muscles where kind of the fascia that makes up the muscle and everything kind of stays short or grows short over time or never gets stretched out all the way. And that causes a chain reaction. But yes, it could. I hear what you're saying, just because of where it was, maybe, wouldn't it just keep doing its job? But no. No, it really can shorten over time.
So if someone's sitting for a long time, that can cause that. But is that because the muscle is tired from being contracted for so long, and that's why it would stay short?
No, so thank you. These are really good questions, right? And it depends. But for everybody, this is really good to think about. So when you're in a seated position, let's talk about just this muscle right now. When you're in a seated position, it's probably not contracted, right? You don't have to keep your iliopsoas. The chair is keeping me in a flexed position, right? It's holding up my leg and my body, and we're bent. So it's not getting tired. Two things are possibly happening. One is the easiest to fix, and stretching really can help this, and massage can really help this, and it can help it in one session. And that is that your brain has stretch reflexors that it's connected to that are in all of your muscles. So your brain is connected to what are called muscle spindles and Golgi tendon organs or Golgi tendon complexes. And spindles are usually in the muscle belly, and Golgi tendon complexes are usually in the tendons, and their job is to measure excessive stretch in the muscle and to stop that muscle from working, and to not allow you to go further, and it's doing that to help prevent you tearing. Literally tearing your muscles. So it will actually shut down muscles and stop you from doing things so that you don't rip a muscle off your bone when you're generating too much force or you're going too far. So it's the reason we can sit here and punch and not throw out our shoulder, because my body literally senses when I'm getting towards the end and it stops that action. We don't realize that because it does it at the last second, but it's pretty reliable. It can be overridden. You can even consciously override it, but in general, it stops muscles working. So, sorry, long-winded answer, but when you sit with these muscles shortened for a long period of time and you don't get up straight all the time and you don't stretch back and things like that, I don't mean from one sitting session, but after a while, your body kind of goes, well, this must be the length of the muscle then. I don't feel safe letting it stretch out. And this happens with everything, by the way. If I want to touch my toes right now, which is very difficult for me to do anyway, but if you massage me and stretch me for a minute, I can touch my toes, but the problem is my stretch receptors go, wait a second, this guy hasn't had his hands down below his knees in a month. It honestly, its job is, I know it sounds funny, it's sad, but true, but its job is to be like, he may not be able to get back up from this, or we might tear, like, we don't have any reason to believe he can go further than that. It doesn't remember 3 months ago when I actually stretched for a change, right? So its job is to stop me. And so those people that have like their stretch sensors set a little too short because they haven't gone to fully erect, they haven't stood up all the way and stretched out those hip flexors, those people respond really well to massage, and I hate to say it after I just talked about pressure points, but pressure point work in the tendons, because that tends to reset the stretch receptors too. So origin, insertion, pressure point work, and just stretching that area out tells the body like, oh, we were able to do that. And the really fancy stretching, the PNF stretching, where I told you where the client resists you, the whole point of PNF stretching is to have the client reset their stretch receptors, because when they pull hard against your stretch, it tells the body like, oh, we can take more force there, I was wrong, and it lets you go further. So that stuff totally happens to ordinary people. They can be very healthy, but their lifestyle has had them sedentary for a while or sitting at that desk for a long time, day after day, and they're fine, but the muscle is set too short, and that really is just a neurological thing, and you can change that by having them resist and having you stretch out their hips in the opposite direction. Done. You have a very happy client, and then you work their neck and whatever else that they probably came in for, because they probably didn't come in for that, and everything will be pretty good for a while. The longer term problem is that some people spend 20 years sitting too long. And then sometimes, remember, and not just us here, but everybody has kind of lied to you in these books that we've showed you. We said, let me stop sharing this really quick. This is actually much more important than what we're doing here. We said, what attaches muscle to muscle, Miss Nahia? I mean, muscle to bone?
That would be the tendons.
Right. So we said, hey, there's this fiber here in the middle that we call muscle, and all it can do is contract. And then we said there's this tendon that attaches it to a bone, right? Never like that, but anyway, attaches it to a bone. Yeah?
Mm-hmm.
The lie part is that makes you honestly think that like, this is just a section of tendon, this is all muscle, and here's tendon. But that's actually not true at all. The tendon or the fascia runs through the entire muscle. The reason, and this is simple but profound to a massage therapist, so I hope you guys will follow this. This is all tendon, right? And by the way, if you tell somebody that, they'll be like, no, it's not. Tendon's on the end, it attaches muscle to bone, and they're right. But what I mean is the fascia that makes up the tendon is all through the muscle. The swollen part here is just stuffed full of actual muscle. That's the puffy part that can contract. It's got fibers woven in with the fascial fibers. And the reason the ends look so thick and white is there's no meat in them. So I want you guys, if you can, I highly invite you to do this from here on out for the rest of your life, because it'll really help you. No longer think about a muscle being attached to bone with tendon on both sides. Think about tendon, and I hope I don't screw you guys up. I know ligaments attach bone to bone. But think about a tendon being like a ligament, but we stuff some contractile tissue in the middle of it. But the fascia is all the way through there from end to end. The only reason the muscle is puffy in the middle is because we've got steak in the middle, the stuff that helps pull those tendons, towards each other. So I make that really big point to tell you that this fascial stuff here can shorten. And bodies do that. Sometimes that fascia shortens over time, and so resetting that muscle isn't going to fix the whole problem because the actual tendinous material in it, which can be lengthened and can be stretched, but it's grown short over time. And it kind of makes sense. If my thumb pad is like this, but I always keep my finger like this, eventually this tissue in here is going to grow shorter because your body's always remodeling itself. Well, now you go and do the PNF stretching and all that kind of stuff, but I still can't pull my finger out because the fascial tissue has gotten shortened. That can be fixed with massage too, but it takes longer stretching because you're trying to override something that's grown that way. We don't have a touch sensor, stretch sensor that's messed up. Stretch sensor I can reset. I can literally push on it, pull on it really hard, kind of open it up, and the brain goes, oh, we can do that again. This is where you've reset that, and the tissue has actually grown shorter just because of my lifestyle. And that takes longer to fix, but it can still be fixed. But fascia changes slower than muscle does. Muscle changes very quick. It's very vascular. The fascia that's woven through muscle is avascular and changes slowly. And that fascia runs through the entire muscle. There's actually tendinous strains to this entire muscle. The only reason it's fat in the middle is because it has the actual muscle, the contractile tissue there. I hope that helped. Do you guys understand that kind of?
Yeah, that's actually really interesting to think about. I was trying to come up with an analogy with like a stuffed pasta, but I was like, wait a minute. Then there'd be like pasta like in like the cheese part or the meat part. So yeah.
But it would be like you're right. So let's use your pasta analogy. We've got, how you hold pasta together like this? And let's suppose it's partially cooked, so it's going to flex for us a little bit. And then you shove meatballs in the middle part of it, right? So it's got the contractile meatballs here, but the pasta runs through the whole thing. And the meatballs are the only part that actually pull everything together and stuff. And at the end, there's no meatballs, so we're back down to pasta at the end. And that really is much more accurate representation of what tendons are. Super duper important. So, I will share one more thing with all of you, and just food for thought. Since you like that, Miss Mejia, this is the really profound thought. So, there's about 600 muscles that make up the body, roughly. And so some really good fasciologists, some really good fascial researchers have started to ask a question that I have a personal answer to. But one of the questions they ask is the body really 650 muscles with other kind of associated like ligaments and fascial stuff kind of tying the body together? Or is the body a giant fascial suit with contractile pockets woven into it? And here's what I mean by that. If you look at me, really, and by the way, I say yes. They say yes and I say yes. This I have a strong opinion about. But there's fascia everywhere. But in this fascia that was my shirt, woven in over here, that's part of the fascia, is the external obliques. So now this part of my shirt can contract. It's still woven into this part of my shirt, which is woven into my pants, which is woven into anything, but it's made for that part. So we actually think of the body as being a fascial suit on many layers with contractile pockets that help pull that suit around. And if you think about it, this is why I've had such a hard time answering questions where people go, well, does that thing weave into that, or where does it actually stop? Or I don't understand why you're telling me everything inserts into the thoracolumbar aponeurosis or here. Because it does, because you're wearing a big gristly skin suit that happens to have muscles in it, we're actually studying the wrong thing. We should be studying the fascia first and the muscles second, but people got fascinated with muscles because they make you move. So, because of that thing there that I drew, I actually believe you're actually wearing a big fascial suit that has contractile pockets with muscles that we name, but they're basically all woven together. And when you go to talk to people at the Avra Lab, they're like, oh yeah, we have to remove all this fascia to even get to see the muscles. We have to trim them out and everything. And it's why Mr. Ibarra's bear walks work so well. That's a fascial move. He is moving the fascial suit. Yes, he's telling you certain muscles to find and things like that, but it's not just a rub the muscle thing. It's a push the fascial suit out. So anyway, just a thought. That's kind of what some people call that anatomy trains. There's a guy very famous who, like Choo Choo Train, anatomy trains, who talks a lot about these long chains of fascia and all the muscles involved in them, but really his whole point is the whole suit is fascial. And I'll try to show you some pictures of that at another lecture so that you can see what I mean, because it's important, because you'll find that just working on people's muscles isn't enough. It is for the simple problems, but the fascial stuff where the body has changed, and your body's fascia is designed to change to meet your lifestyle. It doesn't think about if it's a good or bad change. That's the stuff where the person has the bump on the back of their neck here. That's a fascial buildup. There's not a muscle here. There's not a muscle on C7. There's muscles attached to it. But so why does somebody have a hump over it? That's fascial building up, and that is from tired muscles. My body goes, we can't hold this guy's head up anymore. He's been doing this for 40 years. He's leaned forward. It starts to thicken the fascia there to help support my head. It actually grows differently. Woo! Okay. Good questions. Any other questions right now? Yeah. Okay. Let's take a 15-minute break. That was so profound I have to rest my brain. We'll be back at 4:36, if you don't mind. 4:36. Thank you, everybody. There are 3 words I want to tell you about, because they all make sense when I tell you about each of them. It's anatomy, physiology, and kinesiology. Okay. So, I'm trying to think of an example. This is not a great example, but it's not bad. So let's talk about cars for just a second. Anatomy is just the parts. So anatomy is knowing that that's a carburetor, that's a steering wheel, that's the starter. That you don't even know what they do. You just know the names of them. Anatomy is kind of just knowing the names of stuff. That's your biceps brachii, right? You know the name. That's it. By the way, physiology is starting to learn what those parts do. So you know the carburetor brings in air for the engine to burn, or the steering wheel helps you turn the car. The biceps brachii, now the name is the anatomy, but the physiology is that it can contract. And it's this muscle that can contract. It's what it does. So anatomy is the names of the parts. Physiology is what the parts do. Kinesiology is a study of the parts in motion. So it's a study of motion. And kinesiology says, well, if my bicep pulls here while my tricep's doing this, while my shoulder's doing this, what will happen to the body? And kinesiology is really studying the movement of the body. You need to know the name of the parts and what each part does to figure out the movement of the body. But me just doing this, that probably took 35 muscles. And a whole bunch. I mean, even if we just bit the big ones, it probably took 5 big ones. And so anatomy would be saying, oh, anterior deltoid, and teres minor and infraspinatus, and biceps brachii. Those are just names. Then physiology says, well, we know those can contract. That's what they do. Okay, well, if my kinesiology is saying, then what happens? What's the movement that happens? Kinesiology says, oh, he's contracting his anterior deltoid. Now, believe it or not, everybody, my infraspinatus and teres minor can create a lateral rotation. That's where this came from, right? Right? And then my rear deltoid can pull this out like this. So it's explaining how this happens. And kinesiology is the study of movement. How do I move? How do I walk? How do I lift things? How do I run? How do I punch? How do I pick my nose? How do I pick my friends? Not that part. Anyway, so anatomy is the study of movement, but really it's because we took the parts that we named. I'm sorry, kinesiology is the study of movements, I apologize. Anatomy is the names of the parts. Physiology is what do those parts do, and kinesiology is how do those parts make you move. Study of movement. Does that help? Yes. And so, Ms. Sarno, from your point of view, it's usually putting together a couple of muscles. So right now we've learned, like everybody here in class knows that if my biceps brachii contracts, most likely what's going to happen is it's going to cause me to have to do an elbow flexion. But we don't go walking around doing this all day long. One muscle at a time. We do everything together. And so kinesiology is starting to study the movement of that. And it's also studying things like the anterior pelvic tilt and the posterior pelvic tilt and why am I standing this way. And so it's looking at how things move, but how things move is also how you stand. So if my body is trying, if my body has tension here and it's trying to create a flexion here, yes, that's a movement, but also after a while that becomes the way I stand. So it's how we understand structural anatomy. Yeah. I hope that helped. Yeah, good. And that's what we'll be doing now, starting to put everything together. Kind of exciting. Yeah. So to give everybody an example, when we first started class, I did things where I said, what are the three calves? What are the three calves, Miss Sarno?
Semitendinosus.
No, that's three hamstrings. Yeah.
So,
Yes.
so, and
Soleus.
Soleus and Pantanus.
Plantaris. Yep.
Yep. And I don't know, some.
No.
Okay,
Gastric.
oh, gastrocnemius.
Okay, so what are the three calves again?
Gastrocnemius, soleus, Pantanus.
Thank you. So you just told me their anatomy, their name, and maybe kind of their location, right? Muscles can only do one thing. What's that? Contract. They can only shorten. That's their physiology. So muscles can only do one thing. The heart pumps blood. That's its physiology. But muscles can only do one thing. That's their physiology, and that's contract. So what happens, Ms. Sarno, when the calf muscles contract? What kind of action do you get? What happens?
Fat.
Yes, your foot goes down. So this is called a plantar flexion.
Oh, fantastic.
And that's kind of the kinesiology. So the name is the anatomy. Gastrocnemius plantaris soleus. Boom. Okay, great, I know the name, but I don't know anything. Muscles can only contract. That's their physiology. Kinesiology is what happens when they contract. My foot goes down and movement occurs. Like if I do it right here, I'm not getting taller. I'm plantar flexing. Right? So that's the movement. Kinesiology is the movement when your muscles start working. Yeah. Cool. Really good question. Thank you for asking me to clarify. Anybody else? Maybe? No? All right. Okay, let's get back into muscles. I'm sorry, but I'm really glad you guys brought up these questions. The questions alone imply that we're really moving to new areas, so to speak. Okay, so this is the psoas major, right? Psoas major, but we rarely call it the psoas major. Usually we associate it with the iliacus. And so when we talk about the iliacus and the psoas major together, Mr. Placencia, what do we call those two muscles together? Mr. Placencia, you there? Let's try Miss Munoz. What do we call, we don't usually talk about the psoas major or the iliacus. We usually talk about them together. Do you know what that's called?
The iliopsoas?
Yes, ma'am. Thank you. The iliopsoas. That's exactly right. Okay, so let's move on. Okay, let's actually talk about actual muscles here. So the first one we're going to talk about is the tensor fascia lata, or tensor fascia latae, or tensor fascia latae. I heard a lot of different ways of saying it. When you leave here, everybody will call it the TFL. They don't even bother saying anymore. They just call it the TFL. I remember this muscle because it tenses up a lot of fascia, right? And you want your knee joints to be tight at certain times and loose at other times. And one of the jobs of the tensor fascia lata, that's not really here in your book, is to tighten up the IT band. And to tighten it up so that when I'm cutting laterally, I don't blow out my leg laterally. But here's the kicker, no pun intended. Here's the problem. Okay, this is essentially tensor fascia lata and my IT band here going across my knee. I want it tight when I do lateral movements so that my leg doesn't pop out here. Yes, but when I'm doing movements like this straight forward, I actually don't want it to be tight because guess what happens? The IT band down here pops over my condyles of my tibia and my femur. And it pops over them every time I go like this. And I can even have it pop over up here. It'll pop over my greater trochanter. So if it's tight all the time, it'll actually pop over these bumps in your bones. And if you're a runner or an athlete of some kind, that tension all the time eventually makes it get irritated and swollen. And some people call this IT band syndrome. And it's really inflammation in the IT band. And one of the best things to do for it is loosen up two muscles. What do you suppose the two muscles are that we would loosen when the IT band is too tight? I mean, there's other stuff we might do. But what are the two muscles we're going to loosen up when the IT band is tight? Anybody? Somebody. Okay, I don't know who raised their hand because I can't see everybody right now. I'm sorry, I'm getting used to this new control here. Let's see here. Oh, no, don't have that either. Who raised their hand? Anybody?
I did for a second, but then I wanted other people to answer because, you know.
I appreciate it, but I was like, wow, I really don't understand how to look at this thing. Miss Mejia, since I've ruined your wonderful plan, what two muscles would you loosen up to loosen up the IT band?
You would want to work the gluteus maximus and the tensor fascia lata.
Yeah.
To loosen the IT band because they do the triangle thing that you're talking about.
And because the IT band is basically the tendon of at least the tensor fascia lata. In a way, in a strange way, it's kind of the tendon of the tensor fascia lata and the gluteus maximus. Yeah, thank you. Yeah, good. I'm not saying, that, by the way, you want to work the whole IT band because it can get short too because of some of the stuff we talked about. But that would be a really good starting spot. Yes. Mr. Placenzi, are you there, sir? He hoped. Okay. Miss Hawks, can you tell me what muscles that we just heard, by the way, should be loosened up to loosen up the IT band?
Yeah, the gluteus maximus and the tensor fascia lata.
Thank you.
And the IT band.
Thank you. Awesome. No, that's perfect. That's exactly what I want to hear. Thank you. Miss Mares, what two muscles do we loosen up to loosen up the IT band?
Ms. Hawks just said it. It's the T-band and the gluteus maximus.
Yeah. Cool. Wait. What'd you say? Say it one more time.
Yeah, the T-band and the gluteal maximus.
Okay, but the IT band's not a muscle.
Oh, the TFL.
Thank you. And what does TFL stand for?
The tensor fascia lata.
Thank you, ma'am. That was beautiful. Thank you. All right. We have to be able to find these on a body. And I know it's kind of obvious from this picture and you're like, oh, no problem. But hips get pretty confusing. All right? So, from my back side of my hips, I realize these are not my hips up here, but it's too hard to get me all in the focus here. It goes gluteus maximus, gluteus medius, gluteus minimus, tensor fascia lata, and rectus femoris. And when you trace around somebody's hips, you'll want to be able to find those. So, the book says that the origin, where it starts, where the tensor fascia lata starts, is posterior to the ASIS. Yes. What is the ASIS? Yes. Okay, now I have to, I don't like this.
Yes,
Yeah, please, take it. Thank you, sir.
the anterior superior iliac spine.
Yeah. So everybody, literally, if you find these bumps on your hips right here, which you should right now, because you have to find them on clients, this is your ASIS, your anterior superior iliac spine, and that means that right back here, just right behind it on my crest of my ilium is where my TFL is, tensor fascia lata. Very easy to find on somebody. And super duper helpful. So now you know how to find it. And that's kind of cool. We already know where the glutes are, right? And it inserts into the iliotibial band, and they don't tell you where the iliotibial band goes because it weaves down into the lower leg across the knee. It actually weaves in across the knee. But if you're working it, you want to take it all the way down to the knee, even across the knee if you're gentle. And again, if it gets tight, it actually slips over multiple times over the greater trochanter and the epicondyles of your tibia and your femur. And it actually plucks across them, kind of pluck, pluck, pluck. Well, 3 plucks isn't bad, but 30,000 plucks is really bad. And if you're running someplace or something like that, it gets to be a really big problem. And we see IT bands and tight IT bands in people with back problems too. Because it comes up your leg and hooks into your glutes and into your back, it has a lot to do with back stability too. So it's a pretty common tight muscle. Does anybody remember the direction I prefer to work the IT band? You don't have to do it this way. I don't always do it this way, but there's a good reason.
Is it cross fiber?
Cross fiber is not a bad idea, by the way, sir, if you're trying to break up the tissue itself. But I'm at a direction I like to stroke it, the IT band.
I would say down. You said down, right? Like away from.
Yeah, what do we call that?
Yeah, distal.
Yes, I'm stroking distally, and I'm doing that. I'll show everybody again here, because I think it's worth remembering. Let's look at the whiteboard really fast here. Because our legs are not put together the way we think they are. Because if you've got your, just make sure I'm on the board here. If these are your hips, believe it or not, your femurs actually run in and then hook to your legs. So, if I head up this way, it is likely that I'm going to be heading into bone. And when I get up here, as I cross over here, this is a lot like a pair of scissors. And the tissue gets caught right in there. Gets kind of caught between the bone and my hand. And it's a very painful, annoying sensation. There are ways to counteract it. You can actually tilt your hand out like this so when you go up you don't pinch. But it's not very effective for working the IT band. If I work down, this pinching never occurs. Now, if you guys have watched me massage, I massage up and down, but I massage proximally, actually very lightly, hard distally. because going distal, I can be much harder and much more aggressive without pinching, literally pinching. This isn't figurative, literally having the tissue roll up underneath my hand or whatever and get caught to my hand in the bone in that delightful little pinching sensation, which is horrible. So anyway, that's just a little FYI. I rub the leg both ways, but I don't actually rub it hard unless I'm going distal, away from the hips, and that's why. That's just me. I've never heard that from another therapist, by the way. So I don't mean like it's so profound that I just shared it with you. I just meant like, I think it's really true, but it was just something I just discovered from years of massage and things like that. Okay, so, I know that the actions of this muscle are to flex the hip, medially rotate it, abduct it. I think most of those make sense, right? It's in front and on the side a little bit. So the abduction and the flexion should be obvious. The medial rotation I don't care so much about, but that's because it's slightly diagonal, a little bit in front, and it could slightly medially rotate the hip. It's not a bad thing to know. And sometimes when I'm working hips, I rock the leg a little bit just to get some rotation there. But I want you guys in general, I'm sure there's an exception to this, but in general, when you come across this muscle in your lifetime, your problems are going to be because it's causing an anterior tilt. Or the IT band is too tight and it's causing knee problems and it ties into the back. But my point is, normally it's the hip flexion, the anterior tilt that we care about, right? Some of you, by the way, on the homework, because we didn't say unilateral, bilateral, said, hey, if just this side was tight, it might create a lateral tilt or a lateral elevation. I would agree with that. And this is also the one that if just one side's tight, you could get a torquing, a rotation. Because if I just pull this side down, my body doesn't just go straight forward, it has to do this. And you create this kind of weird rotation because just this side is tight. So that can happen too. Yes, Miss Sarno?
Yeah, it can be like a halfway rotate too.
Yes, it can cause you to rotate because it's trying to bend one side of my body. And because it only bends one side of my body, it starts to rotate me.
And just walk on the not go straight for this and just go follow the
Well, no, ask your question again. I just didn't understand.
the 10 for
Yeah,
karate and if the hip they tilt,
yes.
they can rotate on the side.
Yes. Yes, so you get like, because the hip's only bending in one place, I don't want to over confuse everybody. Like it's still a flexion, but what happens is when I have a flexion on this side only, weird things happen to my hips. They wanna like, it's hard actually, it's actually hard just to flex one hip. And so as you do that, the other one, you start to rotate. Yes, you can get rotations, you can. They're common, by the way, this isn't even uncommon, it's common.
And they can a pinch on the other side.
Sure, can pinch on the other side. That wouldn't surprise me. A lot of people kind of complain about that, a little bit of pinching in their hips, yeah.
Thank you.
And so I'm telling you all this, by the way, you don't have to figure it all out, but when you see somebody who looks a little bit torqued, look and see if they've got tight muscles on one side of their hips and not the other. And then work those tight muscles, right? Stretch those out. And you can actually untorque them. Yes, Miss Mejia, please.
I'm sorry for interrupting you, but I kind of have a question. So,
Please.
when I was in a different college a while ago, I had a teacher who was like severely anteriorly tilted, but she told me that she had like polio or something when she was a kid.
Yeah.
So I don't understand what polio can do. I mean, to like the muscles, why would she be tilted like that? Is what I'm asking.
Got it. I suspect her, I don't know her, right? But I'll tell you, polio can cause permanent paralysis in some of your muscles. And as far as I know, we don't get to pick what muscles those are. I mean, it's not the same ones every time.
Mm-hmm.
But we see it a lot in lower body for some reason. And I honestly don't know why. I just know that's common. Anyway, I suspect she had paralysis in some of her muscles, which means they were ineffective, right? And as strange as it sounds, if I had no muscles in front of my body, I'd have to always stay forward. Because the muscles in front of my body keep me from going over too far backwards. Their job is to flex me. Well, if I don't have anything to flex me, I have to always stay in an extension because my back muscles still work, or my whatever it was on her. Do you understand what I'm saying? I suspect what she was doing was throwing herself off balance because the muscles behind her were working. And she can't afford to lean back here. There's nothing to pull her back up. And I don't, by the way, I don't know if it was her hip flexors, but I'm just saying that type of thing where she's not compensating for shortened muscles, she's actually compensating for the fact that some of these muscles don't work. And in a normal, healthy body, I don't even like to call it that, but in a normal, healthy body, my left side and right side are always fighting. My front and back are always not fighting, but they're always going tweak, 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 tweak. You know, we all do it all day long. We just don't know it because it's millimeters of movement, right? Just keeping me, but I'm doing this all day long. And she probably can't do that. And so this becomes something that works for her. That kind of thing. That's my guess.
Sorry for interrupting.
Miss Mejia?
I don't have to apologize, but I feel bad.
But let's not. Because I really admire you. And I really mean this, by the way. I don't mean to call you out or anything. I think very highly of you, and I meant it from the bottom of my heart that I think your questions drive the conversation. Don't slow it down. And I value them. And you're valuing you more every day. So keep asking. Yeah, you have nothing to apologize for. And I'll tell you, I'll give you, any teacher, by the way, loves questions. What we don't like is when there's nothing, right? So, yeah. Thank you, ma'am. Really good questions. Okay, cool. So, tensor fascia lata, essentially the tendon for the tensor fascia lata is the IT band. The IT band is just a really long, flat tendon. What your book doesn't show you here, and is also important to remember, is the IT band doesn't just kind of go from your hip down across your knee. In a way, it weaves into the fascia around your leg. Because remember, there's fascia around all the big muscles. So the IT band is kind of glued into that fascia around the leg too, so it helps to lock down your entire leg down to your thigh when it needs to, which makes your thighs more powerful when it needs to. So it really is designed as a tension thing on your body, and it's really good when it creates tension. It makes your thighs more powerful. It keeps your knees from blowing out laterally. But then there are certain movements where we would like it to be looser, like when we're running and stuff like that, and we don't want it tight. And if it's really tight, it rubs against the knees and the hip. And so massage can really help with that for sure. When somebody has IT syndrome or swelling or aching in their IT band, especially around the knee and the hip, because that's probably what it's from. And that would be just kind of flushing it out, trying to open up the thing, make it longer, and really work it around the hips. Yeah, and the glutes. Cool? Cool. And we can find the IT band on every single human being in the world by literally finding their anterior superior iliac spine right here, and just literally, it's right behind there, below my hip. It's that muscle. So gluteus maximus, gluteus medius, gluteus minimus, TFL rectus femoris. Rectus femoris comes basically right underneath the as is. And this thing is right behind the as is. So TFL rectus femoris. And that is a very good thing for you all to know. Gluteus maximus, medius minimus, TFL rectus femoris. Because later when I show you stuff to do around the hips, it's very helpful to know where your arm is. And that's a lot of your hip flexors there. Because the TFL, the Sartorius, right there where the rectus femoris is too. Sorry. So really, if we're going to get nitpicky, but it's important, gluteus maximus, medius, minimus, TFL, Sartorius, and rectus femoris are both right here. Cool. Yay. And by the way, in general, I don't know if it's always true, but in general, I probably work this with almost everybody who has back problems. It just seems like they get tight in the glutes and it goes down the TFL almost all the time. So it's just something I commonly do. I'm not saying you should always, but look for it. It's probably tight on somebody. Okay. Let's keep going down here. Then the Sartorius. Who can tell me what muscle group the Sartorius is part of?
doesn't have one.
Thank you. Tapscott's a dirty, rotten liar. It doesn't have a muscle group. It's all by itself. It's not part of the quads. It's not part of the hamstrings. It's not part of the adductors. Everybody correctly labeled that it can flex the hip and flex the knee. I do want to explain something that I don't think is important, but it's important you understand it. Do you see in the book where it says it can medially rotate the flexed knee? Knees actually have a little bit of rotation in them. And what they're saying is when this thing bends, it can actually turn your knee a little bit. Because of where it grabs, it can actually turn the knee a little bit. It's not a big deal. I don't think it'll ever matter in your massage career. It's a very nitpicky kinesiology point to make. And we will never have a test on it or anything. But I just want you to realize what they're saying, I'll show you. What they're saying is this thing comes across like this. Well, when my leg is out like this and it pulls here, it'll actually start to medially rotate my leg a little bit. My actual leg and not my hip. We don't generally care about that. Because by the time people have their knees bent up like that, things like that, it's not really a structural movement problem anymore. But it could mess with knee alignment because it does attach the knee and it can give it a little torque. Yeah. But what we normally care about is the three main movements the Sartorius does. Flexion of the hip, lateral rotation of the hip, flexion of the leg. And this is where you get that hacky sack type stuff. A lot of you said it's good for soccer. Absolutely. Totally a soccer muscle, but totally a hacky sack muscle. And some of you even mentioned that it is nicknamed the Taylor's muscle because that's how tailors sit. Super long muscle. I put this in your homework, but I will say it again. So many massage therapists rub proximally up the leg, and because it's diagonal, they catch it without knowing it. Nobody would. It's a very thin muscle. And then they pop over it right at the end of their stroke, and they think that's a knot in the quads. And they start working that knot, and all you did was slip over the Sartorius. So just be careful you're not working knots that don't exist. That is a problem with trigger points, that part. But that has nothing to do with trigger points. I just meant that's a problem. People think they found a knot and they haven't. And they do it in the back a lot too. They run up the back on the spinal erectors and they run across the rhomboids, bump, 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 bump. And they think they found 4 knots here or 5 knots here. You haven't probably. You've just found tight muscles going this way across. Okay. Conveniently, remember the tensor fascia lata was just right behind my ASIS, my anterior superior iliac spine? The Sartorius is on my anterior superior iliac spine. So when you find your anterior iliac spine and you drop below it in that little divot in your hip, you are on the Sartorius. And then it goes down into your tibia on the proximal medial shaft of the tibia and creates, along with 2 other muscles, the pes anserinus. And many of you in your homework, I don't even think this was asked, but I really appreciated it. Many of you said, hey, the IT band creates lateral stability on the knee. The 3 muscles that come together for the pes anserinus, the Sartorius, the semitendinosus, and the gracilis, create medial stability for the knee. And that's very true. And I love that people pointed that out because people will come to you with knee problems, and I don't want you just thinking quads and hamstrings. Obviously, those can create knee problems. Yeah, they can. I was about to say well, one was more important than the other, but that's not true. Those instabilities in those, like your vastus medialis or lateralis being different tensions can mess up your knee, or your biceps femoris and your semitendinosus can be pulling on each other, causing problems too. But also, so could the TFL gluteus IT band problem over here, or the pes anserinus, which is the Sartorius gracilis, and semitendinosus could cause problems here. And what I'm trying to set you guys up for is that when you leave and go in the real world and somebody walks into your office, that you at least have a place to start. So when they come in with a knee problem, you would at least be like, okay, I know these muscles go across the knee, so I'm going to start looking at all these. Yeah? Yes, Miss Sarno.
And the hamstring muscle will cause that also?
Yes, yes. Hamstrings could be out of balance, and they could be pulling on the knee differently on one side or the other. And yes, that could really cause problems with knee alignment. Yeah.
Thank you.
So one of the first things that good therapists do that's really basic, but not a lot of therapists do it, is when somebody comes in with a joint problem, they at least, if they don't know anything else, they loosen up all the joints that cross, all the muscles that cross over that joint. Like if my shoulder's tight, and you loosen up every muscle that crosses over my shoulder, you've got a pretty good shot of at least loosening up my shoulder. Right? Which leads me to this next question that I'm going to go around the group and ask, just to prepare you all. What muscles cross over the knee joint? I'm not going to ask you to name all of them. I'm going to ask you to name one. So let's see. Mr. Brown. You there, sir?
Yes.
Thank you, sir. Sir, can you tell me a muscle that crosses over the knee joint? That means in some way it affects the knee joint. There's quite a lot of them. Just one, though, sir. Just one muscle.
In the front or in the back? 'Cause doesn't the semimembranosus?
There's semimembranosus we will take. Thank you. Semimembranosus. We'll take it. Mr. Tate, can you tell me another muscle?
The bicep femoris.
Okay, biceps femoris. And what did Mr. Brown say before you? You were correct, by the way. But we had...
He said semitendinosus.
He said semimembranosus, but that's okay. And biceps femoris. Good job, sir. Miss Routson, can you give me another muscle?
I was gonna say Sartorius.
We'll take it. Sartorius. Okay. And what were the other two muscles mentioned so far, Miss Routson?
I don't know. I have someone sitting next to me talking in my ear.
Semimembranosus and biceps femoris.
Thank you.
Miss Walker T, can you give me another muscle?
What about muscle? Can I say IT band?
You can. No, TIT band, but tell me the muscle that involved.
So tensor fascia, lata, and the gluteus neck.
Good. TFL. TFL is great. So obviously IT band, but the TFL that affects it. Okay. We'll take it. Miss Lobitz, can you give me another one?
Did anyone say gracilis yet?
No, we did not say gracilis yet. Good. I love it. Mr. Riedel. We are missing a hamstring, if that helps. And we're missing quite a few other things. But anyway, Mr. Riedel, so a muscle that crosses over the knee. Miss Vincent, a muscle that crosses over the knee. Miss Modest, did you want to comment?
If I'm correct, would it be gastrocnemius?
Yes. Not only is it correct, it's rather brilliant. Because people don't think of calf muscles, Miss Modest, as being knee muscles, but the gastrocnemius flexes the knee. It has two sides to it that go up on both sides of the knee, so if those got unevenly tight or something like that, it could cause all sorts of stuff. That was great. Thank you, ma'am. Miss Allure.
Yes.
Miss Allure, can you tell me any muscles that might cross over the knee joint?
That we haven't already went over?
Yes, yeah.
Would it be the vastus lateralis?
Yeah, that's completely true. You don't sound very confident about that.
Yeah.
Okay, well, we'll take it. We'll let you off the hook. All right. Miss Carodi, can you tell me a muscle that crosses over the knee joint?
Yeah, Sartorius And the expert.
Oh, Sartorius? That is 100% true, but we already heard that one, so you have to give me a different one.
Say that again, I'm sorry.
So we already heard the Sartorius. It is correct, but we already heard that one. Can you give me another one?
You do X. You do X.
What?
All right, let me take care of this. I'll get it to you within the next hour. And
Hold on,
thank you
I'll
for
put the
taking
phone there.
Yeah.
I got you. We got a lot going on. Cool.
You right
So,
Sorry.
that's okay. No, don't be sorry. So can you tell me a muscle that goes over the knee joint? And you're right, Sartorius is correct, but somebody already said that one. So can you think of other muscles that might go over the knee?
The tension fascia,
Yes.
tension fascia lateral.
That is 100% correct too, but somebody already said that too.
And you lay a hole, tibial tractor.
What?
Rectus femoris.
Yes, that works. We will take rectus femoris. That crosses over the knee and the hip joint. Thank you, thank you. Ms. Trotter, you got something for me? Do you want a clue?
I
don't mind giving you a clue.
I'm just trying to think of ones that we haven't said yet, because all I can think of ones that we have said.
Yes, that's true. Well, we mentioned the vastus lateralis and the rectus femoris, which both come from the same muscle group. It's possible other muscles in that group go over the knee as well.
Because, doesn't the vastus, medialis and vastus...
Yeah, stop! That's correct. Vastus medius does go over. Good job. Thank you. Miss Munoz. Hello, ma'am. Can you tell me a muscle that goes over the knee joint?
The vastus intermedius.
Thank you, ma'am. I not only like that answer, I like the fact that you picked it because I was trying to make a point about that group. So yes, that's awesome. Okay. So that takes care of all the quads. Apparently you guys think all the quads insert into the patella via the patella tendon and then insert from the patella to the tibial tuberosity via the patella ligament. And so yes, all four quads cross the knee joint. That is super duper, I don't mean this in a rude way, that's super duper basic anatomy. We should definitely know it. So that's a really good answer. And I got all four quads. Mr. Placencia, sir?
Yes.
Can you tell me a muscle?
Well, we mentioned the gastrocnemius or the plantaris.
We did not mention the plantaris. I love that. Thank you. I also like it again because it's line of thinking. He heard gastrocnemius, so he thought, what other calf muscles cross over? Plantaris is the only other one. So that's there too. That was really good. Thank you. Who have I? Miss Sarno, do you have any muscles? Did I already call on you? I might have. This is hard.
Yeah, everything already there.
Okay. So here, by the way, I've heard 2 hamstrings. If you think the third one also crosses over the knee, you should mention it. I heard semimembranosus and biceps femoris. Oh, that's a quad in front. But there's another semi what?
Semitendinosus.
Thank you. Good. So sounds to me like all 3 hamstrings and all 4 quads cross over the knee joint. Right? Good. And then we got gracilis, which is the only adductor that crosses over the knee joint. And then we got TFL, and I love the kind of implication that even the glute max might be kind of part of the IT band with the TFL. So, okay, that's extremely creative and probably correct. That's above and beyond, but I would agree with those. And then we even went to calves, and we said the gastrocnemius and the plantaris. Yeah, really good. Can anybody think of anything else? Some of your faces tell me. Yes, Mr. Placencia.
Okay, I was going through my flashcards and I found like a new one I'd never even thought about. It's called the Popliteus.
Yeah, I figured that's what Miss EO was going to talk about too. But he beat you to it. It is called the Popliteus, and we have not gotten to it yet. I was not expecting anybody to get it. Don't worry. That was not the point. I just thought of it off the cuff here. The Popliteus is also nicknamed the key that unlocks your knee. When you guys are standing straight up, even though you've got hamstrings back here, they can't really pull you until you start to bend. And the Popliteus is about that long. It goes across your knee. It's in the posterior region. We'll learn about it. And it will actually unlock your knees so your hamstrings can kind of kick in. And it's a tiny muscle. Cool. Anybody else? I can't, by the way, think of another one. I just thought, but I often make mistakes, so I thought I would check with you guys. So if somebody came in and said, my knees ache, they just feel tight, which is actually a pretty common complaint, you'd have to look at 4 quads, 3 hamstrings, and by the way, those 3 hamstrings have 4 heads, 2 calf muscles, the sartorius, 1 adductor, the gracilis, and the key that unlocks the knee. 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 muscles. And that would be a good place to start for Massage 101 for a good therapist. I mean, to me, that should just be what you do. So if this exercise was difficult, that's totally fine. We're only halfway through the course, but start to think in these terms. We're going to be asking more questions about this. Like we would ask, what are the muscles that cross over the shoulder and things like that too. We'll get to that too. Mr. Brown, please, sir.
Can you repeat the name of the one you just said, the Popliteus?
Yeah, yes, it's the Popliteus, I believe.
And that is the fleshy part. Excuse me. Need some water. That's the fleshy part on the posterior side of the knee?
Yeah, it actually kind of runs you right through the back of your knee. It runs diagonal from the medial side of the back of the tibia to the lateral side of the back of the femur. Let me see, hold on. Hold on, sir. I'll see if I can, might be able to pull up a picture here for you. Bear with me. All right. Yeah, I think I can. Tell you what. Let me see if I can put this picture somewhere you can see it. All right. So, oh, come on, downloads, there we go. Okay, this will work, kind of. It's not great, but here, I'll show you something. Hold on, is that now? Window, this one. Here is a picture of the Popliteus muscle. Let me ask you all something. What are these tendons right here on the medial side here? There's actually 3. They're all coming down right below here, below this bump on the tibia on the medial side. What are these 3 tendons? What are they forming?
Are you talking about the goose foot thing again?
Thank you, Miss Routson. This is actually the pes anserinus being formed by, this is the semitendinosus, the gracilis, and the sartorius coming in front. You can barely see it in this picture. And they're meeting down here to form the goose foot. Thank you. That's exactly what it is. Cool? Cool. Yes. Yes, Miss Lobitz, please.
So I thought the rectus femoris was the only quad muscle that went over 2 joints. Are you including the vastuses because of the tendon they insert into?
Yeah, thank you. It does get confusing, so let me just be really clear. Because you're right, I made a big deal about crossing over 2 joints. But what is the main job of the quads? All four.
Knee.
Yeah, I'm sorry.
Extend knee.
Yeah, extend the knee. And they do that because all four hook into tendons that go across the knee. By the way, when I say the muscle crosses over, I don't really mean the fleshy part of the muscle, but the rope it's attached to, the tendon, goes over, and it's meant to bend the knee, right? It's meant to take your knee and extend it. So for all four of them, it doesn't matter if they cross over the hip. All four could lead to problems in the knee. The rectus femoris could lead to problems in the hip and the knee. So I hope I didn't confuse you, but all four go across the knee. All four, like on a knee like this here, it goes down here, this goes down here, this goes down here, and this goes down here, but they all go across the knee, going into this kneecap and the tibial tuberosity. So they all go across the knee.
Okay, I don't remember what it was.
Yeah, I'm sorry, I think somehow it got switched in your head, but yeah. But the rectus femoris, you're absolutely right. The rectus femoris goes all the way up to here, so it crosses over the hip and the knee. But all of them go into across the knee. Cool. Okay. Awesome. All right, Miss Vincent? Miss Vincent? Okay, Mr. Riedel? Okay, all right. Okay. So let's move on. Remember, you can find the sartorius if you can find the bumps on your hip. Right below those bumps on the hip is the rectus femoris and the sartorius. And right behind those bumps in the hip is your tensor fascia lata. Okay, let's share this presentation now. All right. Okay. So this is an excellent picture of the sartorius coming with the gracilis, coming with the semitendinosus down into, underneath this person's hand, the pes anserinus. And this is an excellent picture of the back of your leg, so you can see how the biceps femoris and the semitendinosus and things like that wrap around both sides of your knee. I'm starting to see how complex knees are. All right, and last but not least, we've talked about the TFL today and the IT band that's connected to. We've talked about the sartorius. Those are both start in about the same area. Then we have two muscles here that are extremely hard to palpate. And that's the psoas major and the iliacus. They are referred to together because we believe they always act together. They go to the same location and they do the same thing. They both flex your hip and they both insert into the lesser trochanter. Why will you never ever palpate the lesser trochanter? Even if you tried, I don't think you can palpate it really. Not very easily, but why would it be difficult to palpate the lesser trochanter? Anybody?
Is it because it's behind the bone? The figure?
It's because it's behind a whole lot of muscle. So.
Oh, that's it. Yeah.
So, just remember, everybody. Let's look at just this leg over here. This is really how the femur runs. It runs kind of diagonally towards your center here, right? So, but that's not how legs look to us. When we look at them, they look fairly straight. I understand they taper, but they look fairly straight. And here's why. They've got a massive muscle on the outside here that likes to fill in this area. What's this massive muscle?
Is that the vastus lateralis?
It is, sir. It's the vastus lateralis, and it actually helps even out that side of the leg. And it gets very thick down here, so you don't notice the fact that the bone's going this way. And what do we have up here? What muscle might this be right here? Anybody? There's a couple answers that could be right. Just tell me one of them.
Pectineus.
Pectineus, thank you. And then what do you get up here then? If that's the pectineus, what's this roughly?
Brevis.
Adductor brevis. If that's adductor brevis, what's this?
Adductor longus?
Yep. What's this?
Gracilis.
Gracilis, thank you, because it crossed over the knee joint. And then, of course, behind all this, we've got the adductor magnus. Look how different this leg is than this one. This leg looks like it's actually kind of just tapering in here, but it's fairly straight. So, let me show you the greater trochanter is out here. It's the big bump you feel on the side of your hip. The lesser trochanter is right here. Or in this model, it's right there. That is a tremendous amount of tissue to get through to get to that thing. That's why you'll probably never feel it. It's another reason why I like to stretch this muscle than try to massage it. Because in order to rub it, I'd have to have my hand all the way up right next to your groin. I think too high even for me. And I'll drape people really high and tight and get really close, but I still want to respect them. So it's pretty high up there. And then I've got to go through their inner thigh, which we all know our inner thighs are more sensitive, to get to this attachment. And it's just really hard, and it's way up there. I mean, it's way up there. That's your pubic symphysis. It's deep up in there. And there's a lot of fascia up in there too, so good luck doing that. So anyway, I just want to kind of explain that. So the other way for me to get to those muscles is to go through the stomach, but it just doesn't work really well, so I like to stretch them. Right? But the thing I want you to remember about them is their general origin and their general insertion, so that you understand how they operate. All right? And Miss Mejia was really helpful actually with this. She called this the iliac fossa, right? And it is the iliac fossa. And so the iliacus actually attaches in here, and it comes down and inserts into this little leg bone right here. Comes from here to here. Well, you can't really get in here very easily. You can, by the way, and some people get your fingers right about there. But boy, the amount of work it took to get in there and how vulnerable they feel for me to get my hand in here. So the origin of the iliacus is the iliac fossa, and it inserts into the lesser trochanter. The origin of the psoas major is the back of your lumbar region. Your books will say things like the body of your lumbar vertebrae. They'll sometimes say the body and the transverse processes of your lumbar vertebrae. So your back has a curve that's natural like this. This muscle is pulling it from here. If it's tight, it's actually going to give you more of a curve. It's actually going to pull your back out front sometimes. So it can fight with your back and stuff. But anyway, it starts on the lumbar region anteriorly. The part we'll never touch. We're used to rubbing back here. We'll never touch this. We would have to kill somebody. But it too comes down and runs into the lesser trochanter. So iliacus goes from the iliac fossa into the lesser trochanter. Psoas major goes from your lumbar vertebrae to the lesser trochanter. Yes, Miss Mejia, please.
Those are going through the foramen in the hip, right? The hole.
They're not going through the foramen in the hip.
Oh.
I'm glad you asked that, but they're not. It's very hard to tell from a two-dimensional thing, but they are going. Here, I'll just tape one up really fast, just so you can see. There we go. There we go. Oh, this will work though. So again, it would cover everything, but this is a pretty good model. You've got this guy. This is the psoas major going down across and into the leg here. The iliacus is down here too. And they don't ever hit the holes here. They're going down through this groove, right off the side of your pubic bone on both sides, if that helps. You don't really have any muscles going through this. You have muscles attached to it on both sides, but they're under here. So this is going kind of splitting off to both sides and going under here. And this is why it's so hard to get to. There just aren't a lot of good places to get to it on. Any other questions on that? Okay. I'm going to make one last call for Mr. Riedel or Miss Vincent.
I'm here.
Oh, okay, sir. You weren't there for a while, sir. Sir, can you tell me the 4 quad muscles that cross over the knee? Mr. Riedel?
Yeah.
Can you tell me can you tell me the muscles that cross over the knee?
The gracilis.
Yes.
The sartorius.
Yes.
Rectus femoris.
Yes.
And I'm not sure what the other one is.
Cool. So rectus femoris definitely crosses over the knee. What muscle group is that part of?
The quads?
Yes, sir. And so do any of the other quads cross over the knee?
Nope.
Okay, all of them do.
Oh, whoops.
All 4 quads cross over the knee, and they all help with the knee extension. That's their main job. I know I keep talking about anterior tilts and things like that, but that's their main job. Cool. So all 4 quads cross over the knee. Do any of the hamstrings cross over the knee?
The rectus femoris, right?
Yeah, but that's a quad. So rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius, those all cross over the knee. It's a big question, by the way, I'm throwing at you. But do the hamstrings that are in the posterior side of your femur cross over the knee?
Yeah, I don't really know.
Okay. All 3 hamstrings cross over the knee too. So all your quads kind of extend out your knee, all your hamstrings kind of curl them back, flex them back. And then you were correct in the ones you got on the side where you said the sartorius comes over the side, the gracilis comes down to the side, and by the way, the semitendinosus, which is a hamstring, comes to the side. They all insert in the pes anserinus. And then what we were also discussing in class was that the TFL, the tensor fascia lata, crosses over the knee in the sense that your IT band is part of that. It all is really long and goes down across the knee to support the lateral side.
Okay.
Cool.
Well, does that really count though? Because it's not really a muscle, it's just a tendon.
Yes, but could it be a tendon for a particular muscle, since tendons attach muscle to bone?
Yeah, it could.
Okay, maybe the tendon for the tensor fascia lata?
Mm-hmm.
Cool, yeah. Cool, thank you, sir. Miss Vincent? Okay. All right. Okay, everybody. So, Iliopsoas is really your iliacus and your psoas major, right? And by the way, not to confuse everybody, but these don't cross over the knee, right? These cross over your hip. And that's all they do. Basically, all they do is a flexion of the hip. But we discussed that some crazy things can happen, right? And we discussed that if just one side is tight, you can even get this thing to start rotating the body. Because it is still actually doing an anterior tilt, but that anterior tilt on one side kind of causes the body to go, I don't know what else to do but to rotate. And that's why it's significant too. And when you see that, you will see lots of differences from left to right and right to left. Right? In the beginning of class, by the way, we kept it simple. We talked about lots of differences from front to back. We said if your hamstrings are tight, they're probably fighting with your quads, right? And we talked about, but now we're getting much trickier. We're saying if there's a torquing, you'll kind of notice the left rectus femoris is tight and the right one is loose, or vice versa. You'll notice that kind of stuff, which is really helpful because then you're like, well, that's just wrong. I'm going to work on the tight muscles on this other side. That is very common. And we'll often see when there's torquing, we'll see the whole back. And some of you apply this in your homework, which I really liked. You'll start to sometimes see some scoliosis in the back, because now we're not exaggerating the curves front or back. We're actually messing with the way the back is going straight up, because that turning is causing it to have to deal with that turning. So we'll see that sometimes too. A temporary scoliosis. It's not really permanent. All right. Let me just share this with you really quick, and then we're basically done. Just want to make sure that you're really clear. Here is a beautiful picture of the iliacus filling in the entire inside of the hip. Remember, you can't touch this. And then going down into the lesser trochanter. And, oh, it's not a beautiful picture of the psoas major, but at least it shows you where it goes from. The psoas major attaches to the body, and the transverse processes of L1 through 4, your lumbar vertebrae basically, and then still goes down into the lesser trochanter. So both those cause a flexion of the hip. They are, by the way, your iliopsoas is considered your #1 hip flexors. I've been telling you about the rectus femoris and things like that, but these guys, their job is to flex your hip. And because they can flex your hip, they can cause an anterior tilt. Yes, Miss Mejia, please.
On the action, it was saying with the origin fixed with the insertion fixed. What does that mean exactly?
Let's see. It said, I don't know what you're talking about. It says, where are you talking about? Is it on the slide we have up right now?
Yeah, it's on the slide. It says actions with the origin fixed, flex the hip, and then with the insertion fixed, flex the trunk.
I love
What does
this.
that mean?
Okay, I'll tell you. I actually love that they put that in there. And thank you again. So, if I was floating in outer space, I know this is kind of hard to imagine, but I really want you to think about this. If I was floating in outer space, and I don't have very long legs, and this is me floating by, okay? And I'm in outer space, you don't have a classroom behind me to figure out like how I'm oriented or anything. Is there a difference between my femurs coming up or my hips coming to my femur? No, there isn't. In outer space, I can be upside down, and the fact is this angle just gets closer together. And that's because the iliopsoas contracted. So what they're telling you is, with the insertion fixed, so hold on, if your legs are fixed, because this is the insertion, and they contract, what's going to happen? I'm gonna flex the hip. I'm going to anteriorly tilt. If this is fixed and it starts contracting, I'm going to lift my leg. I won't have any choice. And this is, I'm really glad you asked this. This is kind of the point I tried to make all along, which is to us in kinesiology, all we say is this hip closes here. But we all live in a world with gravity, and so it's a lot different me bending over than it is me lifting my leg up, right? But from a kinesiology point of view, the same muscle did that, the same thing happened. The only thing that's different there is gravity. And so if we're really trying to understand movements of joints, we don't really actually usually take into account gravity very much. Don't get me wrong, there are times we really want to, because the way gravity pulls in your body affects your posture. I'm not trying to discount gravity. I'm just telling you from a point of talking about the coxal joint, there is no difference between me raising both my legs or me bending over at the hip. It's the same thing. It's the same joint bending. Right? So this is a silly example, but in a way, it's like this is the same as me coming to it. Right? Or a pull down is the same as a pull up to my arm. At the gym, I'm pulling down a thing, so you see me doing this, but that's the same as me doing this. So one thing, my origin went to the insertion, the other thing, the insertion went to the origin, but from a point of study of my shoulder and my elbow, the same exact action happened, and that's what they're trying to tell you in the book. And now that you know that, you can kind of throw away what the book told you, because it's kind of an obvious point. The fact is, the hip flexes, because that's what the muscle does. Yeah. Yes, Miss Sarno.
And if psoas major muscle get short in the lumbar, the spine of the lumbar, and the disc between that, and in the trans by pinching, like the disc push out and hit the nerve, and it caused the problem with that or not?
Yes. So Miss Sarno, gosh, you guys are lucky you have each other in class. Otherwise, this wouldn't work. Miss Sarno's exactly right. Tension in the iliopsoas, well, tension in the psoas major, doesn't just pull the back forward, right? But it can actually pull the vertebrae down on top of each other. And especially if it's kind of trying to pull my back forward and my spinal erectors try to pull it back and they're starting to fight each other, well, that's fine. But if you've ever been in a fight between two people, you get squeezed in the middle. And if they're pulling me forward and pulling me back, that's kind of rocking me forward and rocking me back. But what happens in the end is I end up just getting compressed. And when I get compressed, then you get herniated discs. And they pinch on nerves like this. And you will get a lot of clients like this where you're not actually trying to fix the problem. The disc is herniated. You're trying to get the pressure off it so it quits hitting this nerve coming out here. And you would do that by working both sides of the muscles, right? You would get the iliopsoas in front and you'd get the, it would be another example when I said here with the knee, work every muscle that crosses over the knee, work every muscle that crosses over this. But because you guys are going to be advanced therapists, you won't just think about the back muscles. You'll be like, oh, gosh, if their abs are too tight, or more importantly, if their psoas major is too tight, then they're pulling on both sides and I need to loosen up both those. So I'm going to stretch out the iliopsoas and I'm going to stretch out the erector spinae muscles. That would be a very good place to start. And people will get a lot of relief from that because if I'm used to going around with a little bulging disc and you've released that pressure, it won't stay that way. I'll have to come back for a massage next week, but this is a huge relief. And the problem with this is, by the way, every time you feel pain, what do? You tighten up. So now I get my back hurts. I've had my back hurt before. The first thing you do is, oh. But what do? I'm contracting everything right now. So you are going to teach them to uncontract, and so they're not pinching on that. You're absolutely right, Miss Arno. Brilliant. Well said. Yeah, well said. And by the way, there is a psoas minor, just so we all know. There is a psoas minor, but few people have it. I think about 40% of the population have it, and it's a very tiny muscle, and it runs right by the psoas major, so you don't have to worry about it. But I just wanted to explain to you why we don't ever talk about the psoas minor. It's because it's very tiny, and it kind of attaches your spine to your hip, and it's just very tiny. It's not really important. But it is right on the psoas major, and I honestly don't think that there's a human being alive that could tell the difference between the two. I have never once worked on a client digging in their stomach and been like, oh, that's the minor and not the major. They're right next to each other and you couldn't even tell if somebody had it. But it does help the body flex in that area a little bit. Yeah, if somebody does have it. Cool? Any other questions? Those were really good questions.